welcome you to this webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of many resources made available by the Prescribers Clinical Support System Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Today's webinar is in collaboration with nursing colleagues in Canada, the Registered Nurses Association of Ontario, and the Opioid Awareness, Treatment, and Education through the Center for Addiction and Mental Health. Just a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer screen, you will see a control panel. In the lower portion of that panel, participants can type in a question or comment and submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we are unable to get to all your questions in the allotted time, our presenters have agreed to respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on the PCSSO website in the near future. They will also be posted on the INSA website at www.intnsa.org. So now let me turn to Sabrina Morelli, who's the Program Manager for the Mental Health and Addictions Initiative with the Registered Nurses Association of Ontario's International Affairs and Best Practice Guidelines Center. Ms. Morelli will introduce today's webinar presenter. Sabrina?
Good morning, everyone. On behalf of the Registered Nurses Association of Ontario and the Center for Addiction and Mental Health, the Opioid Awareness, Treatment, and Education Initiative, I want to welcome you to today's webinar. The RNAO is a professional organization for nurses in Ontario and since 1925 has advocated for healthy public policy, promoted excellence in nursing practice, advances nurses' contribution into shaping the healthcare system, and influence decisions that affect nurses and the public that they serve. A signature program of the Registered Nurses Association of Ontario is the International Affairs and Best Practice Guidelines Center, whose focus is on the development, dissemination, implementation, and evaluation of clinical and healthy work environment best practice guidelines. One of the initiatives at the RNAO is the Mental Health and Addiction Initiative, funded through the Ontario Ministry of Health and Long-Term Care. The goal of the Mental Health and Addiction Initiative is to build capacity amongst nurses and other healthcare professionals to implement and sustain addictions and mental health best practices in daily nursing practice. To learn more about the RNAO, please visit www.rnao.ca. Our second partner today in this webinar series is the Opiate Initiative at the Center for Mental Health and Addiction. The Opiate Initiative stands for Opioid Awareness, Treatment, and Education, and is funded through the Ontario Ministry of Health and Long-Term Care. The Opiate Initiative is involved with face-to-face education and training, along with online training, webinars, dissemination of resources. The initiative works with people with lived experience to help share their voice, along with primary care professionals, allied service providers, families, and youth. It is our pleasure to be here with you today, and let me introduce the speaker for today's webinar. The speaker for today's webinar is Lori Naylor. Lori is a registered social worker who works with the Breakaway Satellite Opiate Addiction Treatment Program since 1999 as an addiction therapist. She has a passionate interest in the connection between trauma and addiction and has been active in providing clinical education on this topic in conferences and to agencies across Canada. Lori is a facilitator for the Provincial Opiate Project, having presented a variety of webinars and training, including methadone maintenance treatment and chronic pain, methadone maintenance treatment and trauma, and OxyContin changes. She is the author in the Center for Mental Health and Addictions text entitled Highs and Lows, A Canadian Perspective on Women and Substance Abuse, released in 2007. On the topics of creating comprehensive methadone treatment for women. In addition, she is a member of the University of Toronto and the Center for Mental Health and Addiction faculty, where she trains physicians, pharmacists, and counselors in the Opioid Dependency Treatment Certificate Program. Lori also runs a private psychotherapy practice since 1996. Welcome, Ms. Naylor.
Thank you, Sabrina. Good morning, everybody. I think it's morning where everybody is. It's so exciting to be talking with people all across the province and then across the border. I recognize that some of the things are going to be unique to our situation in Ontario, and I hope that we'll have a chance to share some of the experiences of folks who are in different areas in the U.S. So today we're going to start with our learning objectives. Today we're going to talk about opioids. Hopefully by the end we'll have increased our knowledge and understanding about what opioids are, some issues around problematic use, who's using opioids, some risk and protective factors, health promotion issues, opioids in pregnancy we'll touch on, treatment approaches, overdose prevention, supporting full recovery, and opiate substitution therapy. So let's start with what are opioids. So take us all back to our pharmacology courses back in the day. So opioids are psychoactive chemicals that work by binding to our natural opioid receptors in our brain. They're types of painkillers or analgesics that are sometimes called narcotic pain relievers. They have positive effects associated with the analgesic qualities. Anyone who's had any kind of dental work or surgery will be very happy for the existence of opioids. But they also have risks associated with misuse and the drug's depressant qualities. So we'll start with, as we go on, we'll try to be a little bit interactive and talk about some myths and facts. So the first one will be opiate is a synonym for opioid. Is that true or false? We won't have a chance to have a dialogue about that, so we'll get you to internally make that guess, and then I'll give you the correct answer. And the answer is false. Opiates are just one of the classes of opioids, and we'll go through some of those. A couple of comments about this slide. The term narcotic comes from the Greek word to numb or deaden. In the field of law enforcement, narcotics are referred to as all drugs of abuse. And we know in healthcare that narcotics are really, in the pharmacological sense, just the pain relievers. And so the definition varies depending on what field you're coming from. So looking at the different classes of opioids, there's 4 classes of opioids. The ones that are naturally produced in our bodies. So any of us who participate in strong aerobic activity have reached that kind of runner's high. That's the endorphins that are naturally produced when you lift up a baby, when you have an orgasm. Those are the natural endorphins that our bodies produce. So those are the first type. The second, derived from the opium poppy family, such as codeine and morphine. Those are the opiates. And then the larger group, the opioids include the semi-synthetic, Percocet, Oxy-Neo, heroin, Dilaudid, Percodan, oxycodone. And I recognize that some of the names in the U.S. are going to be slightly different than they are in Canada. So I'll ask our U.S. colleagues to correct the names if we're getting a difference there. And then the fully synthetic group are those such as Demerol, Suboxone, fentanyl, and methadone. And we'll be talking about methadone and Suboxone at greater length today. And we'll talk about some of the common prescription opioids and their ingredients. So in Canada, we have the Tylenol 2, 3, and 4, which are codeine with acetaminophen. In Canada, we have Percocet, oxycodone with acetaminophen. We also have Percodan, which is oxycodone with ASA. Oxy-Neo and OxyContin was the oxycodone in the time-release formula. And we'll speak a bit more about that. Dilaudid is hydromorphone. We'll do another myth check. Acetaminophen toxicity. Since the common sign of acetaminophen toxicity is vomiting, it's not possible to be seriously harmed from taking too much Tylenol or Percocet. Is that true or false? Well, it's actually false. When used appropriately, side effects of acetaminophen are rare, but liver damage and coma can occur when large doses of acetaminophen are taken. In some cases, there's no specific signs of overdose within the first 24 hours of acetaminophen poisoning, so people delay treatment because they think they're okay. And the liver can also be damaged by chronic use or concomitant use of acetaminophen with alcohol and other drugs. Some more prescription opioids and their ingredients: MS-Contin, MS-Eslon, which is morphine. The Duragesic patch in Canada is known as fentanyl, and we're having quite a bit of trouble with abuse of that on the streets right now. I'm not sure if that's also true in the U.S., where people are scraping the adhesive off and boiling it down and injecting it or chewing it. And we've had a number of overdoses because of the high potency of fentanyl. Tolwyn and Demerol are a couple of other opioids. So as prescribed, the intended use of opioids is for physical pain management, and then the secondary use is for treatment of addiction to other opioids in maintenance or substitution therapies. And we'll talk some more about pain. It's a very complex issue, and it's much more than the scope of our 1 hour can take care of today. So here are a couple of videos and webinars that can help you explore some more about pain management. So we'll talk a bit about problematic use. There's a relationship between the amount of opioid medicine prescribed in Canada and the increasing level of opioid abuse and opioid-related deaths among youth in Ontario. And this is a 2009 CAMH study. What are the risks of opioid use and abuse? Well, we have dependence, addiction, overdose, withdrawal, health risks, and diversion. I'll go through those a little bit. Physical dependence occurs when tolerance is developed and the body becomes so used to having a substance that it can't function normally without it, without physical withdrawal. Psychological dependence occurs when a person feels he or she needs to function or to feel comfortable, so that's more of an emotional impact of withdrawal. Addiction has a number of different definitions that we don't entirely agree on, including the new DSM-5. But addiction is characterized by the 4 C's. We talk about loss of control over use, continued use despite harmful consequences, compulsion to use, and craving. And the overlap between dependence and addiction is controversial. Overdose. In an overdose, the thinking and the breathing slows down, and the brain damage and trauma and death can occur because, especially with the opioids, there's central nervous system depressants, and so people stop breathing. Excuse me. The health risks associated. It's risky to take drugs while even a proper dose is being established for pain relief, to seek an opioid high while taking opioids as prescribed, or to mix opioids with alcohol or other sedatives such as benzodiazepines. It's also a tricky time when you're starting or increasing a dose because we never know precisely what that dose will do to a person's central nervous system. So the titration process to an appropriate dose, where we're balancing out the sedation with the pain relief or the substitution effect, is tricky. Diversion occurs when drugs from a legitimate source are diverted to an illegal source, so giving or selling drugs or interceptions between the manufacturer and the pharmacy. So let's check in with another myth. Is it true that most people who use opioids go on to develop a dependence or addiction? What do you think? It's false. Most people who use opioids do not develop a dependence or addiction. It's unclear exactly what proportion of people do develop problematic use, but some studies suggest that it may be as high as 1/3. So let's look at the substance use continuum. And substance use is has its historical roots that go back for centuries, and in other species too. We've all probably seen that YouTube video of the elephants eating the fermented fruit off the tree and getting drunk. Substance use is something that people like to do, and animals like to do too. And so we go in our society everywhere from no use, and some people choose to not use for religious or spiritual or other kinds of cultural reasons, all the way to occasional use, circumstantial use, experimental use, especially among young people. Then moving up the continuum to regular use, longer-term use, problematic use. And then we start to get into the red zone of tolerance and eventually dependence and addiction. I don't think I need to elaborate on that. It seems pretty self-explanatory. We talked already about addiction is characterized by the 4 C's again: a loss of control over use, continued use despite harmful consequences, compulsion to use, and craving. So why are opioids so prone to abuse? Why is this such a big problem? Recognizing that opioids are powerful drugs and address a number of different problems. So initially they're designed to numb physical pain, and they're very effective for that. At the same time, recognizing that the neurobiological roots in our brain, that the physical and emotional pain centers have the same root. And so while we're numbing the physical pain, we're also numbing emotional pain. And when people find that that's a source and a shortcut to numbing emotional pain, some people get into problematic use. Some people are using to avoid withdrawal once they become dependent physically, because sudden cessation of an opioid will result in uncomfortable and painful withdrawal symptoms. Some people use for the euphoric effect, separate from the physical pain and emotional pain, that especially at the beginning of use in the experimentation, there is a euphoric effect in an uninitiated person, and some use for relaxation. So let's look at what are the warning signs that you may see in your position as a nurse. Excuse me. When we start to see early renewal of prescriptions, people start making excuses, or I lost my prescription, or doc, I need to, I'm going to be going away next week, so I need to have, so they're not using as prescribed. They're doubling up, or they're using earlier than is prescribed. We also notice double doctoring, where people are going to numerous providers. And our pharmacology system here in Ontario is starting to address that through some administrative online tracking of who's getting opiates. Diversion, so if people are taking other people's medication. And if there are new pain symptoms coming up, warning signs meaning that the initial dose is no longer taking care of the pain, so that's a sign of some tolerance occurring. So let's talk a bit about withdrawal. Remembering that withdrawal effects are tremendously uncomfortable, but not life-threatening. People don't die from withdrawal. Physical effects usually subside after a week. The emotional effects of withdrawal can last quite a bit longer, especially the agitation, restlessness, and anxiety, and that kind of, that piece of the withdrawal leads people to a high risk of relapse and drive people to use again. Withdrawal effects can occur even after first use. So looking at some of the things associated, the withdrawal effects associated with sudden cessation: insomnia, anxiety, restlessness, agitation. Sweating is one of the biggest signs that we see. Body aches, bone aches, muscle cramps, and spasms. Chills, shivering, clammy skin, what's sometimes called the chicken skin. Diarrhea and intestinal distress. And then again, with the emotional side, depression, hopelessness, and exhaustion related to the insomnia and the sleep deprivation. So let's talk a bit about tolerance. Tolerance is when the receptor sites begin to get clogged up and more doses needed to achieve the same effect. And that can be the same euphoric effect or the same pain management effect, because remembering that there's several ways that people use opioids. Tolerance increases the risk of physical and psychological dependence. In fact, it's one of the signs of dependence. Here's an important piece about opioids: that tolerance for euphoria increases more rapidly than the tolerance, the CNS impacts. So people can continue to seek the euphoria of drugs by jacking up their dose, but are ignoring the overdose cues, the slowed breathing. So that puts people at risk of overdose. So let's talk about addiction a little bit. Anyone, and most of us have someone in our lives who's been impacted by addiction, can see how devastating it can be. And it affects almost all of the aspects of our lives: employment, our emotional health, our physical health, our family relationships, our leisure relationships, social relationships, legal status, education, and finances. So determining whether drug use is a problem isn't always about how much and how often, which are usually some of the first assessment tools that we ask, but more about the psychosocial impact in various life areas. So let's think about who's using opioids. Dr. Mandel from the CPSO was quoted a couple of years ago about saying, Ontario is in the middle of a public health crisis, a crisis stemming from inappropriate prescribing, dispensing, and illicit use of opioids and other narcotics. So recognizing that prescribing, dispensing, and illicit use, we have a whole group of people who are associated. So the prescribing, that's our healthcare providers and our MDs. So they've been prescribing inappropriately, and so there's been one branch of this addressing that. Dispensing, our pharmacies are involved with getting the administration of tracking devices working more clearly. And then the illicit use of side, that involves law enforcement, addiction treatment, families, and our communities, and our lawmakers. So the opioid issue is affecting many parts of the community. In Ontario, between 1991 and 2009, the number of prescriptions for oxycodone drugs rose by 850%. 850%. It's a kind of shocking statistic. And concomitantly, between 1991 and 2004, deaths in Ontario from opioid use doubled from 13 deaths to 27.2 deaths per million. I heard a statistic that shocked me a couple of weeks ago, that there have been as many opioid overdoses as there have been motor vehicle deaths in the province last year. In 2009-2010, the Ministry of Health and Long-Term Care in Ontario spent $156 million on narcotics for people who are on Ontario Drug Benefit Programs. So that's people who are on disability, who are on general welfare, who are seniors, and $54 million on OxyContin alone. So, and that's not even illicit use, that's all prescribed use. Excuse me. And this is addressing from the treatment perspective. Between 2000 and 2004, controlled release oxycodone increased from 3.8 to 55.4 of the total opioid admissions into inpatient treatment centers and outpatient treatment centers. And long-acting oxycodone was associated with a 5-fold increase in oxycodone-related mortality. Now, since that time, OxyContin was removed from the market in Ontario and was delisted from the Ontario Drug Benefit Program, but there's been some changes with the introduction of OxyNeo, and now generic OxyContin has returned to the market and is now back on the streets. So the approach that the government took was partially effective, but it also led to some downsides, which I'll speak of in the future. Prescription opioid misuse has been Ontario's fastest growing problem substance and the third top presenting problem substance for new admissions. So DATIS is our tracking system for drug treatment in the province. The expectation when OxyContin was discontinued in 2012, they thought that they would see a decrease in people coming into treatment, but the trend was not what was expected. People ended up actually substituting other opioids such as fentanyl and morphine, and there was a group of overdoses that were, to some people, unexpected, and to other people, kind of expected outcome. It seems to have leveled off since that time, as people who were dependent and street involved found other drugs. At the clinic that I work, we had a large number of admissions to methadone and other substitution care. So that was a good outcome of that. So you'll see from this list, the purple slide is the number of female clients who are using opioids, and our women are presenting addiction treatment more than the men. Among the general population in Ontario, you can see here on this slide, any non-medical use of prescription opioid pain relievers in the past year by gender, age, and region, and that's adults in 2011. Although the previous slide showed a large amount of women who are presenting for treatment, this one shows that non-medical use of pain relievers were 2.3 times higher among men than women. And it begs the question, why men? One theory is that men are not as commonly seeking treatment for their emotional pain, but they will seek treatment for their physical pain. So they'll go to the doc and say, "Oh, my back's hurting," but then when they are prescribed opioids, they're finding that the opioids are providing some of that emotional relief that they weren't able to talk about it. You know, we all know about men's socialization and "I don't want to talk about it" kinds of stuff. The other theory about that is that, you know, more men work in physical jobs such as construction and may be presenting with sports injuries. So this is why we may be seeing more men. Among youth, it's important to assess and treat the young women. As we see here, the group of women spiked in 2011 to 2012. 40% of those females who were presenting for treatment were showing opioid use. The Ontario Student Drug Use and Health Survey is something that's done by CAMH regularly. And for the first time, 9,000 students, grades 7 to 12 in 2011, 14% were showing non-medical use of opioid pain relievers. Prescription opioid pain relievers such as Tylenol-3 and Percocet for non-medical purposes. So this is experimentation around the euphoria and the mood-altering properties. Almost 67% of those reported obtaining the drugs from home. So there's a heads up to all of us to go and check what's in our cabinets at home. Here's a couple of resources for parents that might be useful. Some key messages that parents can try to convey to their kids. Building some healthy relationships so that it's easier for kids to talk. And remember that old book, How to Talk So Your Kids Will Listen, and How to Listen So Your Kids Will Talk? Some clear rules that are about never taking someone else's medicine. Safe and secure storage and keeping track of pills. Cleaning out your medicine cabinet at least once a year. Most pharmacists will accept your discarded drugs and dispose of them safely. And to get help early. In Ontario, we have a drug and alcohol helpline that is staffed 24 hours a day, so parents can get some help. And a couple of other documents put out by CAMH, the brochure about Percs, Oxys, and other pain pills, and some other youth-appropriate flyers that are put out. So let's talk about risk and protective factors, remembering that they don't have a simple cause and effect relationship, but these are trends and tendencies that set people up for use and for recovery. So remembering some of the risk factors, life events and environmental stressors. We're going to talk in a couple of slides about the social determinants of health that are associated with this. The psychological vulnerabilities, we're going to talk also about concurrent disorders and other illnesses and medications. If we're aware of some of the risk factors, we can target prevention and education specifically to those areas. So if you have a patient who is prescribed pain medication and you know that they also have a history of depression or a post-traumatic stress disorder, or they've just had a divorce or lost their job, they're going to be more at risk of developing a potential misuse of the opioids, aside from someone who didn't have those risk factors. And protective factors, the things that, you know, when we look at different people in the same families, we wonder, why did this one become addicted and why did that one not? And some of the factors that are protective include personal and social competence. If people are doing well in other areas of their life, they're less at risk. Feeling in control of one's life, you know, that that they're on track and they're kind of driving the bus. An optimistic attitude has been shown to be associated with, as a protective factor, the ability to detach from conflict and not get pulled into the vortex, and a willingness to seek support, to not be isolated. Some of the populations that are at greater risk, as we mentioned before, adolescents, older adults who come with more physical health issues and are already on typically more medication, people who have a family history or personal history of substance use issues, and people with a personal history of mood and anxiety disorders, including the post-traumatic stress disorder. We'll touch on concurrent disorders. From the Ontario data, non-medical prescription opioid use has reported to be significantly higher among those reporting elevated psychological distress. So seeing that little Venn diagram there, the brown area in the center, there's a higher overlap when people are already struggling with mental health problems. So let's talk a little bit about health promotion, and this is a role that many nurses are involved in. And this is probably a review, so I won't spend too much time here. So some strategies: building healthy policy, developing personal skills, reorienting health services to a prevention and promotion orientation, creating supportive environments, and strengthening community actions. Excellent slide about the social determinant of health, and we touched on this earlier. The factors that are associated with healthy lifestyles include food safety, access to education, access to satisfying work, living and working conditions such as living in poverty and having healthy housing. Water and sanitation is a big issue, healthcare services and access to healthcare services, which I know is on the mind of all of our American folks right now, and safe housing. So what works? Knowing that building those resiliency and protective factors, the agency that I work with opened a safe housing project several years ago, and some of our most chronic users stabilized after many, many years, and it was shocking, yet not shocking, but very rewarding to see that once these folks got stable housing, other things and other problems in their lives, other chaos, fell away, and they were able to really move forward in significant ways. Balancing out health and safety, and we'll talk a little bit about that. Setting goals based on evidence and best practices, and we'll move to talking about harm reduction in a minute about that. Using a comprehensive approach, a range of strategies, a wraparound approach. Supporting collaborations, using the determinants of health and a population health approach. And there's a webinar that you can look at that's listed here. Opioids in pregnancy. So the first note is that opioids cross the placenta. So withdrawal is a really important issue if a woman is using opioids and she finds herself pregnant. The risk to the fetus and to the infant, the withdrawal has the same physical effect on the fetus as it does to the woman. So the evidence is that it's safer for a woman to continue to monitor safe opioid replacement treatment than it is for her to withdraw. It's also safe for the infant, although some are affected by neonatal abstinence syndrome, which occurs to some infants who are born to mothers who are dependent on opioids. But the biggest risk is withdrawal associated with premature miscarriage and placental abruption if a mother is going through withdrawal. So if tapering has to be done, the safest time is to be done between 14 and 32 weeks. Although it's not recommended, this is the safest period where it can be done, and at a very slow rate per day. And needs to stop if there are any signs of withdrawal that are happening. So the goals during pregnancy are to minimize withdrawal, prevent relapses, and use maintenance medication. The safety considerations: to provide prenatal care and psychosocial treatment, which is one of the side effects of being in methadone care, that women have more access to regular health care. Monitor for the partner's use of drugs and or violence in the relationship, remembering that violence against women increases during pregnancy. And considering taking action if the child's at risk under the Child and Family Services Act. You all have child welfare obligations. It's important to look out for polydrug use and tobacco, which puts the infant at a high risk for SIDS. While a woman is addressing one of her addictions, it's been shown that quitting smoking is it's an easier task, and the highest rate for women to be quitting smoking is when they're pregnant. You know, we'll do things for a babe that we won't do for ourselves. And so here's some more information about resources on opioids and pregnancy. There's an excellent webinar by Dr. Alice Ordine that you can watch. And so we're on to treating opioid dependence. I'm going to go through this a little bit quickly because I think you're probably somewhat familiar with the stages of change. I'll just remind you of Prochaska and DiClementi's work, and pre-contemplation, contemplation, preparation, action, and maintenance. The overall goal of harm reduction, and I think we all participate in harm reduction whether we recognize it or not, to increase the awareness of the risks of behavior and to provide people with tools and resources they can use to decrease the risk of harm to themselves or others. So how many of you drove to work today and wore your seatbelt? So you're partaking in a high-risk activity, that's driving fast in a vehicle, in city traffic or on the highway, but reducing the harm associated with that high-risk activity by belting yourself into the car. That's a harm reduction approach. So how does harm reduction work with substance abuse? Well, it's considered the best practice approach to addiction, and that's based in the evidence. It takes into account individual preference, that we don't all start at the same place, and we're not all in the same place as far as our goals. It can include, but isn't limited to, abstinence. The Substance Abuse Network of Ontario says that harm reduction means focusing on the most immediate and achievable changes that can reduce the threat of health and well-being to the user and to society. The core principles of harm reduction, that it's a morally neutral position. It recognizes that people are responsible for making and will take their own decisions about treatment and substance use. We're committed to strategies that are practical and effective. It focuses on the harms rather than the use, the consequences of the use. The emphasis on the goals, recognizing that clients have multiple goals for treatment and not all of them may be attainable at one time. That flexibility in treatment options, it's important to recognize that use a variety of interventions in treatment to respond where the client is at in their recovery. Redirecting resources from drug enforcement to education, to prevention, to treatment. Redirecting intervention efforts from targeting illicit drugs to targeting drugs that are more harmful to society, such as tobacco and alcohol. It's a broad perspective, accepting that quitting the substance may not be realistic or desirable for a client. You have to start where the client is at and consider what their goals are. And the evaluation piece, redefining outcome measures so that success is not measured just by decreased levels of substance use, but also by decreasing levels of death, disease, crime, and suffering, recognizing the small victories. And fighting stigma is a big piece of harm reduction, reducing the stigmatizing and marginalizing effect of traditional approaches to substance use treatment. So why take a harm reduction approach? The research shows it results in more positive relationships. Engagement in treatment is central. We can't work with people who don't show up. So being non-confrontational, it helps to build positive relationships. It helps engage a person who might otherwise be isolated. They don't have to meet a criteria of abstinence before they start to get connected. It starts where a person's at now. It addresses personal priorities, such as improving a housing situation or improving personal health. It helps a person become more stable, making it possible to address substance use and other issues. It's a hopeful approach. It lowers the bar for success and allows attainable goals. It helps avoid crises by addressing important determinants of health. And it's less costly to society overall. It reduces the cost of emergency health care, of hospitalization, and institutionalization. Here's an example of a harm reduction approach that's going on in Toronto right now. We have a naloxone training program that's run by our public health and department, sorry. And so what it does is provide kits and training to anyone who declares themselves to be an opioid user. And so it helps people to prevent death in the case of an opioid overdose. It's an inverse agonist, so that it stops the drug from having an effect. The next comment is incorrect. It's commonly administered or self-administered intramuscularly, not intravenously, and so it's very easy for anybody to inject themselves or to a friend who happens to be having an overdose. So we're going to move along quickly to some treatment approaches to opioids. The range can go from controlled use, tapering, withdrawal management, opiate substitution therapies, and alternative therapies. And I encourage you to check out this webinar. So controlled use is taking as prescribed. That's with some support around, especially for folks who are pain management clients, and uses of alternative pain management strategies such as acupuncture, TENS machines, therapy with hot and cold, physical activity, relaxation, distraction, and through counseling we can work with tolerance of pain tolerance, supporting tapering and withdrawal. So for folks whose tolerance is not very high yet, or who might not be interested in a maintenance or a substitution program, slowly decreasing opioid use with the intent to quit. The ideal approach includes planning with the client, the service provider, physician, and a support person with close monitoring. Preparing for withdrawal requires lots of support. So preparing a safe and comfortable environment, ensuring access to a support person, getting lots of rest, decreased noise levels, cool clothing, warm compresses, baths, staying hydrated, consulting with a physician about other medications known as a quit kit. So, for example, if we have homeless clients who are thinking about doing the cold turkey withdrawal, it's important to coach them around having a safe place to crash. If you're living outside, it might not be the place that you want to be doing a cold turkey withdrawal. Supporting full recovery requires a continuum of care, and it goes through the whole range of comprehensive supports. So here are 3 substitution treatment options: methadone, buprenorphine, and Suboxone. So methadone, it's not normally green, it's normally orange. So it's a long-acting oral opiate analgesic designed back in the Second World War to fight for pain management. But it's now used as a substitution drug given an appropriate dose to opioid-dependent patients. It's normally a once-a-day oral orange juice drink. It suppresses the symptoms of opioid withdrawal for 24 to 36 hours, reduces cravings. At the correct dose, it doesn't induce sedation or intoxication or euphoria, and that's an important consideration, that at the correct dose. It reduces pain for short periods of time, and it's still used for some folks who, as an analgesic, but the dose required to keep somebody out of withdrawal is a different treatment than when it's used for pain. It's cross-tolerant to other opiates, so it's useful for all kinds of opiate dependence, not just for heroin or oxys. Components of a successful methadone maintenance treatment program involve counseling with the client and their family if they're involved, urine drug screens, integrated medical counseling and admin services, availability of a variety of psychosocial services, highly trained staff and involvement of support people, and a long-term involvement. The best results are shown to be at least 2 years treatment. It's a very effective treatment that's been used since the 60s, so we've had lots of research around it, and it's shown to decrease illicit drug use, decrease criminal activity, improve employment rates, psychological status, 11 times less mortality than those who are using heroin. It suppresses withdrawal symptoms and cravings and doesn't induce sedation or euphoria at the correct dose. It's helpful for those who might have tried those other treatment options that I spoke of before, the cold turkey or the supported taper. Those with persistent pain may be helped by methadone because they're getting a stable dose. It's important that people have a safe, stable living environment. They need to be able to get to their clinic or pharmacy without difficulty. It's an intensive program where people need to have frequent, they need to leave urine screens weekly, they need to have frequent contact with their pharmacist and with their physician. So it requires a commitment to a long term. And people benefit from a support from a case manager. The daily dose is administered at a pharmacy, supervised by a nurse or pharmacist. And in Ontario, there are contracts required to ensure safety and adherence to the program, which is somewhat demanding. A carry dose is a take-home dose, which is not permitted in Ontario in the first 2 months of treatment. Depending on stability, clients can receive an extra carry a week for each month of the program, and the maximum in Ontario is 6 per week. It helps lives by retaining people in treatment. It suppresses opioid use, reduces criminal behaviors, mortality rates, improves physical and mental health because people have more contacts with healthcare providers. It reduces risk behaviors for HIV, HCV, and STIs, improves outcomes for women who are pregnant, and improves social functioning and quality of life. So in summary, it's effective. It's a long-acting opioid agonist that is administered daily. Treatment is very specific to the individual. There's a high risk of relapse if treatment is discontinued, and withdrawal symptoms can be severe. There's a high risk of overdose for people who relapse as well because of the change in tolerance. The induction period is particularly dangerous time because, again, unknown tolerance. With long-term supports in place, treatment outcomes are quite good. And remembering that without judgment, some individuals will use methadone for the rest of their lives. We'll talk quickly about buprenorphine and Suboxone. Suboxone is a partial opioid agonist. It is buprenorphine hydrochloride. It contains a small dose of naloxone, which is not effective in the gut. It only is included in the drug to deter injection if the drug is deterred to the streets. Theoretically, it has a less severe withdrawal than methadone, but that has not played out in the experience of our clients. Some clients state that Suboxone feels less emotionally addictive than methadone. The different formulation and where it hits us on our neuroreceptor sites can mean that Suboxone has, it feels like a more activating drug. The trouble with Suboxone is that there's a ceiling on its activity. It makes it safer that people can't overdose on it. However, it's only, equipotency is only equal to about 50 to 60 milligrams of methadone. So if somebody had a very high tolerance and required more than 60 milligrams of methadone to keep them out of withdrawal, Suboxone would not hold them. Suboxone being a tablet is associated with less stigma. There are fewer regulations, so it's more portable for some folks. And so we're early in our careers in Canada with Suboxone. It's only been on the market about 5 years or so. It's been used a lot more, I think, in the States and certainly in Europe, and they've had tons of excellent outcomes with it. So that's the end of my, my gallop. The rest of these, you have some resources mentioned in this tutorial, and so I'll pass that along to Sabrina.
I wanted to review some of the resources additionally to what Lori has provided that will provide you support in clinical practice. So just again, another follow-up that this is a RNAO in conjunction with the Center for Mental Health and Addictions, and the Center, the International Nursing Society on Addictions is producing a 5-part series on our webinars. Our next webinar will be held on November the 5th, 2013. And same time at 11 o'clock, and it's on stigma, opioids, and clinical care from the nurse's perspective. RNAO also has a whole slew of mental health and addiction-related best practice guidelines, including supporting clients on methadone maintenance treatment. All of these guidelines can be found at www.rnao.ca. Additionally, here are some more resources. There is a mental health webpage for your viewing pleasure, which has all of our resources there. You can go to rnao.ca and just search Mental Health and Addictions Initiative, and all of the associated resources will come up. There is an online community of practice for nurses and other healthcare professionals where professionals can connect online and network and share events and resources as well. There is an e-learning program for methadone maintenance treatment, and soon to be released an e-learn for Addictions 101 for adults, or substance use disorders for adults. All of our guidelines are also available on mobile apps and downloadable on Blackberries, Androids, and iPhones. as well as we have virtual speaker bureaus as well on the website. So at this point, I will pass it over to Deborah to open up for questions and answers. Thank you.
Lori, thank you very much for your presentation, and Sabrina for going through those resources. Very impressive resources that are provided through RNAO. As the questions were coming in, I think your presentation actually addressed many of these. So there were questions about pregnancy, the risk of withdrawal during pregnancy, and some of the consequences and how it can be, those risks can be offset. So you really showed that later in the presentation on slides 42 and 45. And then the shout out for the December 11th webinar related to pregnancy will also be a great one for people to tune into. So let me address a couple of questions that came in. Lori, for you. Are you aware of any trials with nasally administered naloxone?
Well, I work in frontline, and I'm not as connected to research, so I'm afraid I'm not.
So that's an opportunity for somebody to do a literature search and to look to see if there's some current trials going on, or if that's indicated. Another question is, could you differentiate between Suboxone and Subutex with respect to buprenorphine?
Certainly.
And you may have done that, but
Suboxone is buprenorphine hydrochloride plus naloxone, so that's the oxone ending. The naloxone is added as a deterrent to injection. Subutex is the mono product, and for pregnant women, this is the drug that needs to be used because the naloxone is found to be teratogenic. Subutex is the buprenorphine hydrochloride only medication.
Okay, and that may kind of lead into more of an explanation about why you would use buprenorphine instead of Suboxone. Anything that you want to expand on there?
Do you mean regularly or during pregnancy?
I think this is a general, in general. I think you did address that in terms of pregnancy, but anything in terms of a general selection of buprenorphine instead of Suboxone.
I think that the feedback I get from most of our clients is that the issue of stigma and methadone is one of the big deterrents from wanting to use it. Suboxone, when you go to your pharmacy, you don't have to stand in the line with the stigmatized folks. You don't have to wait around, although you're supposed to wait until the sublingual tablet dissolves. So people talk about it having being just another medication that they're taking that has far less stigma attached to it. In addition, I mentioned the activating properties that Suboxone has related to the methadone attaches to the mu receptor site and the kappa receptor site. Suboxone does not attach to the kappa receptor site, and that's known as sort of the downer site that some people get associated with some opioids. So it doesn't have that, and some people talk about it feeling almost like an antidepressant. So that's anecdotal, that antidepressant piece, but some folks have found it that way. Theoretically, it is supposed to be less sticky and easier to taper down from. And if you talk to our client group, this is the mythology that's going around, that it's way easier to get off of at the end, which is many of the clients' goals to get off of. It's not been supported in our practice.
Mm-hmm. Back to the nasal administration, comment from somebody from the U.S. in the New York State Department of Health uses injectable and nasal kits for overdose prevention kits.
Oh, that's great.
So some sharing of across the border practices. What are the options for those who need more than 60 milligrams of methadone to stabilize but are not best suited for methadone because they're using benzodiazepines?
That's a good question. I think that requires a lot of clinical judgment. Folks who are using benzos are just monitored more quickly in our practice, monitored more closely through the urine screens and would not have access to carry doses.
Right. So really that the whole idea of someone who's on benzodiazepines really presents a much more complex clinical situation that needs very close monitoring.
Yes, and I think that, in fact, that's one of the situations where physicians are encouraged to seek a more experienced physician as a consult if they're dealing with that. The highest number of overdoses in methadone-related deaths are associated with sedating drugs such as alcohol and benzodiazepines.
There's a question that came in about someone with chronic pain. And this is a patient with gastric paresis with chronic pain with minimal digestion. Is there anything that you could suggest? And I'm presuming, well, I maybe need more clarification. I'm not sure if this is associated with treating the pain or someone who has an addiction. So can you speak to anything related to that with patients that have paresis with chronic pain?
I understand that the Suboxone is available in a patch now, so maybe there's some future directions there.
Great. So in other words, other routes of administration where we're not dependent on an oral medication then.
Also remembering that the Suboxone is sublingual, and it doesn't pass through the GI system. It goes into the bloodstream. So
and that
might be a better drug of choice.
Right, and that was a comment that just popped in, is that there are sublingual strips also available. Right. So great recommendations. We'll take one more question before we wrap up. What are physicians or prescribers in Ontario using in the last year and a half since Oxy was taken off the market? And why take it off when it was reformulated 3 years ago to be much less abusable? Or was the use of just the generic?
In Ontario, the Oxy Neo was only released in 2012. So we were a couple of years behind you folks around that. So the reformulation happened at the same time that the OxyContin came off the market. At the same time, within weeks of the Oxy Neo, as it's called here, being on the market, you could Google how to cook that up and inject it. So our clients are ahead of us because the power of the addiction is very compelling. I don't know, sorry, the second half of that question, could you repeat it?
So it was whether they used the generic because the reformulation was less abusable, or whether you just used the generic.
I think some physicians changed to different formulations of pain medication as well. And so people needed, they may have changed from codeine to morphine, or, OxyContin to Percocet.
Well, thank you. There may be some additional questions that we didn't have time to get to, and then some of the general questions regarding the presentation being available have been answered through the chat feature. So our time is now up. Thank you all for participating in this webinar. Shortly you'll receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey, and we would ask you to take a few minutes to access it and provide your feedback on today's session. And there's also an evaluation that our colleagues in Canada will ask you to complete as well. The webinar today was recorded and will be posted on the website of the Physicians Clinical Support System Opioid Therapies in the near future. That website is www.pcss-o.org. And also the information will be available on the INSA website at www.intnsa.org as well. The calendar of upcoming events are also posted on the website, so in addition to the ones that we're providing through INSA and through RNAO and CIMH as our partners, there are others by our partners on PCSSO that are being offered. We do hope that you'll join us for upcoming sessions, and we'll continue to collaborate with our Canadian nurse colleagues in several more webinars this year through 2014. Thank you and have a great day.
Thank you.